Good afternoon, and welcome to the Influenza Staffing Strategy presentation for 2017. My name is John Farrell, and I'm the lead analyst for this project. In this presentation, we'll identify patients who are most at risk, determine where and when staffing demand is the highest, and consider next steps and recommendation for the upcoming influenza season. We'll focus on three major questions: who is at risk, where to prioritize, and when should we prioritize. And with that, I want us to keep in mind that influenza and pneumonia is the 12th leading cause of mortality in the United States, according to the CDC. The need to prioritize and allocate medical personnel is essential for minimizing staffing demands in these high-risk areas and gives greater capacity for hospitals and clinics to care for more patients and lower influenza-related complications. So now, we'll assess who are these at-risk patients. Our guiding hypothesis for this project is that if you're an older individual, then your risk for influenza-related complications will increase dramatically. So, we separated the data into two different groups, the non-vulnerable and vulnerable populations. We determined these groups based off of age. So if you are age 65 or older, then you would be considered in the vulnerable age population, according to the CDC. Through our analysis, we can see that our hypothesis is supported by the data. The vulnerable population comprised of 90.01% of mortalities recorded from last year. It's clear that individuals age 65 or older will continue to be the focus of providing medical care and treatment for the upcoming season. With our patients identified, we can now take a look at where to prioritize staff. To determine where we would look to allocate staff, I assessed the mortality data and created a map which shows the total number of mortalities by state. The darker the color reflects the higher number of mortalities. From this, we can see most of the mortalities are in clusters of nearby states, but are scattered around the Midwest, the Northeast, and the South. California, however, breaks that trend, as it is the only state where other nearby states have relatively much less mortalities compared to itself. If we were to rank these states based on mortalities, we can see that these mortalities are occurring in densely metropolitan areas. So prioritizing staff in these areas will have the best impact to support medical facilities. So now we know the kinds of patients to support, as well as where should staff be allocated. The last major question is, when should we deploy our staff? To determine this, I took a look at historical data from 2009 to 2016 by month to see if any trends emerged. As we can see from the graph, mortalities are quite high from January to April. It then bottoms out at around July and August, and then it rises again in October to December. We can see that the influenza season lasts for about 7 months, with an off-season occurring in later spring and early fall. This means that we should deploy staff from October to April to have the most impact against this disease. So to recap our insights, our findings reinforce that individuals at age 65 or older end up being the most susceptible to influenza-related complications. People that live in the Midwest, Northeast, South, and West regions of the country have the most influenza mortalities and occur in densely metropolitan areas. The influenza season lasts from October to April. And in terms of our strategy for the upcoming influenza season, I'd recommend to prioritize allocating medical staff in states with the highest number of influenza mortalities, such as California, New York, Texas, and Pennsylvania. We should deploy staff during October to April, where hospitalizations for influenza are at their highest. and we want to prioritize patients that are age 65 or older, as they are more likely to suffer from influenza-related complications. Pending approval, there are some potential avenues for insight that could be explored. Namely, we can consider additional factors like vaccination data in these major cities to better understand what may cause these complications to occur. Also, we can explore additional related data sets such as child influenza mortalities, as they are not considered in the scope of this project due to the limited data. However, children under the age of 5 would fit in the vulnerable population definition. And with that, thank you for attending the presentation, and I've included an appendix if you'd like to explore the project further. Thank you and have a great day.